cancers combined. Despite this, screening for asymptomatic cancer is widely accepted, but screening for asymptomatic ASCV is not. As a nation, we spend over 20 times more on screening for asymptomatic cancer than for atherosclerotic cardiovascular disease, the underlying cause of heart attacks. Coronary artery calcium scoring, or just CAC, costs less than $200 pretty much everywhere in the US, sometimes as little as $100, compared to $3,000 for like colonoscopy and mammogram for cancer screening. And that's why it's out of pocket. So CAC is out of pocket. It's gone down. It used to be $200. I think it's like virtually $100, which is everywhere I look. And why would you do that? It's really helpful because CAC is helpful for, what it does, it diagnoses whether a patient has CAD or not. And then once they have that diagnosis, then you can start doing a workup. So like, not only do you get the baseline, so it's like, mild, moderate or high risk, but you can also diagnose it. And that's like what it's best for, is stratifying risk when you're not sure what to do with someone. And it's also okay to do that. Sometimes I'll do that first. It just depends on the case. Keep in mind, someone comes in and maybe they're on a budget, who knows, maybe they're Medicare and you don't bill Medicare and they have to pay through your doctor account for the labs. Then you could just do the CAC to start the show. And if it's, like, let's just say a 65-year-old woman has calcium score of 2, you can calm down, you can back off on the blood work, you can do, a less aggressive treatment approach and less aggressive testing. CAC measures the amount of calcium in the walls of coronary arteries. Because plaque contains a relatively predictable amount of calcium, it can be used as a surrogate to estimate total plaque burden. High-quality data supports the use of CAC and risk stratification. The amount of calcium is highly predictive of cardiovascular death and the chances of MI and stroke. A score of 400 or more is particularly concerning. A score of 400 is correlated with a 10-year risk of heart attack, stroke, or death of 25%. And the rate of growth matters too. This is why, in some cases you do want to do serial CAC because it's cheap and it's okay to do and you can track the progress. Doing a single one, like if it's low, right? Let's just say it's, under 10, you could maybe do one in 2 years. If you do see one of 400, I would probably go straight to cardiac or CTA, coronary CTA. Coronary calcium scoring depends on calcium content to determine the plaque burden. This is why you get a calcium volume. It will not show new uncalcified plaque, does not evaluate the vulnerability of plaque, and does not indicate percent occlusion. It is very helpful in the diagnosis of CAD and useful for tracking plaque progression or regression. Let's talk about that real quick. It doesn't have to be that complicated, but it's a key point that gets missed by 99% of most doctors that do these. So what if the calcium score, here's a question. A patient calcium score goes up 10% in 1 year, okay? Is that alarming or is that considered pretty good? Up. So let's say you did it today, and then a year you did it again, and their annualized increase in plaque was 10%. Well, I'll just answer, sorry. So according to the literature, if it's 15% growth or less, the patient is being managed properly, and often you'll have to really teach them because they don't like it. It's 13% growth, and they're like super alarmed. They think that's like interest rate or something. But it's not. In an untreated patient, you can see they'll be in the 20s, 26, 30. I've had, worst I've ever seen is 100%, and you'll see a few of those.
Wait, can you go back to that? I mean, if someone starts out at a 10 and goes to...
Well, I meant percent. Yeah, like so if they...
But if someone starts out at 200 to 300, is that a very different situation?
Well, kind of, because they're higher risk already, so that's a good point. But rate of progression, it's kind of what I meant was there's the raw score and there's rate of progression. So it would also be concerning if someone, like they didn't have a really high level, right? Like maybe 20, but it went up 100%. That's like, that's actually worse than having a patient at 400 who goes up 6%, because it looks like they're stable. So you don't want runaway disease. Okay. And the other thing is too, if you do enough calcium scoring, you will see some negative numbers. I say negative numbers, and patients are like, what does that mean? Then I say plaque regression, and they say, what does that mean? It means that the calcium content went down. This is most oftenly seen in a patient that's making massive changes. So they were overweight, they weren't doing anything right, like an average American, unhealthy. They come to see you, and you just turn things around. They were barely even on, maybe they're on a B vitamin, and their diet is standard, right? And they're drinking too much alcohol, and they're eating the wrong fats, and having too much salt, and et cetera, not eating vegetables. You do this, and you lower their lipids, and you improve their blood pressure, and they start exercising. You can see it's such a dramatic change that you can see some plaque regression. And then the opposite can also occur, especially if patients are on statins and they start rapidly stabilizing plaque. They can kind of, I call it hypercalcification. And that is where things get really confusing. Sometimes the primary care doctors will order these, and their calcium score will like double, or say 20% growth in 1 year, because it's percent growth really matters a lot too. And the patient will, so they won't have a good answer, and then they'll get on Google and they'll start looking around, and they'll find you if you blog and put blog articles on your website, and then you can say, well, here's the thing. We don't know if you're healing plaque or you're just growing more new plaque that's then calcifying. So that's what you don't know. There's only two reasons for an out of control CAC score: a bunch of new plaque that's then calcifying, or the new plaque that's vulnerable is now healing and becoming calcified. And you don't know which